Good evening, everybody. My name is Dr. Matthew Holder, and I'm the President-elect of the American Academy of Developmental Medicine and Dentistry, and I'm your host tonight for the Physician Education and Developmental Disabilities webinar series, presented in partnership with the Florida Center for Inclusive Communities and sponsored by the United States Department of Health and Human Services Administration on Intellectual and Developmental Disabilities and the Florida Developmental Disabilities Council. This is the 10th installment of our 12-part series occurring every Tuesday night at 6 p.m. Eastern Time through October 9th. Each part of this series is accredited by the American Academy of Family Physicians for 1 credit hour of AAFP prescribed credit and is recognized by the AMA as equivalent to 1 hour of AMA Category 1 credit. Archives of each presentation are available about 1 week after the live event at www.aadmd.org and are accredited for CME credit for the next 2 years. For those of you who are not physicians, you may also obtain a certificate of completion. Just keep in mind that we are only able to award continuing medical education credit for this webinar series. Toward the end of the presentation tonight, as always, there will be time for some questions. So if you have any questions, please type them in the question box of your control panel as you think of them. We will get through as many questions as possible during the time we have left. So tonight's presentation really embodies the spirit of everything that we are trying to accomplish with this webinar series. For those of you who have watched the other webinars, it should be no secret that people with intellectual and developmental disabilities do not, as a whole, have access to the quality health services that they need. The purpose of this webinar series is to serve as a first step in improving that quality. But quality improvement is an ongoing process, and it relies on more than just attending a few lectures or watching a few webinars. It is something that every clinician should actively be engaged in, and in order to provide better care to their patients, and especially to their patients with intellectual and developmental disabilities. While we have given you some tools to improve that care that you will deliver, after this series is over, it will be up to you to take the next steps on your own. So this may mean modifying your practice environment or identifying quality sources of information that can support you as you provide care to people with intellectual and developmental disabilities. And it may also mean establishing a methodology by which you can analyze how you are providing care and how you can improve the outcomes of that care. So tonight we have 2 great speakers that can help you along this path. Dr. Carl Tyler is an associate professor in family medicine at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. He is a coordinator for geriatric education and research at the Fairview Hospital Cleveland Clinic Family Medicine Residency in Cleveland, Ohio. And for over 20 years, his main clinical and research focus has been to improve the health and primary care of adults and elders with intellectual and developmental disabilities. Dr. Tyler has published research and clinical review articles related to the primary care of adults with IDD in the Journal of Family Practice, Clinical Geriatrics, Gerontology, and Geriatrics Education, and Primary Care Clinics in Office Practice. He also co-authored a clinical pocket manual particularly useful for primary care physicians entitled Intellectual Disabilities at Your Fingertips, a healthcare resource, which I would highly recommend as a resource, by the way. His present research utilizes electronic health record data and practice-based research methods to improve healthcare in this population. Speaking first tonight, however, is Charm Tometz. Ms. Tometz is a mother of 3, including a 37-year-old severely disabled son named Scott, who requires total care and resides at home. Valuing the contributions Scott brings to her family dynamics has led her down the path of becoming a disability advocate and helping developmentally disabled individuals and their families access supports and services to remain safe, healthy, and supported in the community. She has served the disabled community as an advocate and volunteer for over 34 years in several positions, some of which include the following: as a board member and chair for the Community Living Service Coordination Task Force for the Florida Developmental Disabilities Council, as a parent liaison for Hillsborough County in Florida, as chair of the Suncoast Region Family Care Council, as a district representative for Family Care Statewide Council, As a board member of the Interagency Quality Council and as an advisory member of the University Center for Excellence at USF. So I couldn't be more thrilled to have both of these speakers with us here tonight. And so I would just like to turn the presentation over to Charm. If you are ready, I'd like to turn it over to you. Charm, can you hear me?
Yes, I can, Matt. Thank you. Hi, everybody. I'm Charm, and this is our son, Scott. And actually, Scotty just had a birthday. He's now 38. And as Matt said, he's our oldest child. He's our oldest of three. He sustained brain injury at birth due to hypoglycemia. And so he's severely globally delayed and totally dependent on us for all of his needs. When Scotty was born, and for about 12 years after that, doctors kept recommending that we institutionalize Scott, that he would ruin not only our lives, but the lives of our other two children. And we chose not to do that. He has been totally integrated in our family, in the community, with our friends, and it has been a wonderful journey. We call him the King, and he's had a safe and healthy life. He has made profound contributions. I mean, the journey that we've gone with Scotty has taken us to places that we never, I never thought that I would have gotten this involved with the disability community, and but he's been inspirational, empowering, and truly life-altering. He's helped us help other families access supports and services, and we've always had kind of a can-do kind of an attitude. He's one of the participating model patients here at USF at the med school, and then we also have the students come to visit us in our home, which is really kind of fun because they get a first-hand look at how a family functions with an individual with the developmental disabilities. And most recently, one of the things that we've discovered is that we're helping our elderly neighbors now, access supports and services. It's kind of a natural fit for us because we've been doing this for 38 years. So we have elderly neighbors who are in their 90s, and helping them bring supports and services into their homes. So in a way, we're kind of like paying it forward. But has it been easy? No, but really raising children is not easy. It's been tough, but it's been rewarding and very enlightening. But I think the number one lesson that Scotty taught me in the very beginning is, as a young mom, is I realized that this child was going to be dependent on us for the rest of his life. So when the other two came along, I realized that it was my mom. It was our job as parents to make them as independent as possible. And my mantra was to them: you have two arms that work, two legs that work, and a darn good brain. Your job is to go to work. And that's what they did. We supported them with their school. And I remembered these two kids that the doctor said Scotty would ruin their lives. They're both doctors today. I have one for the body and one for our minds, so we're set. But we've always kept a really positive attitude. My thing was, you can either be happy or sad, and we chose to be happy, and we always found a way to make it work. If I was granted one wish, if there's anything I could change, my one wish would be to change the way supports and services are doled out to families. I would really, in the past, the gold standard was, these children belong in institutions or group homes or now nursing homes, and I'd really like to see that change and to give families a shot and get the supports and services into homes and at least try, because number one, it's cheaper, it's safer, and it's healthier for our kids to live in the community, and they really have a lot to offer. Finding the right doctor, this was really challenging for us. There were numerous times that we would, we'd walk into a doctor's office and they're like, we don't know nothing about these kind of kids. Why are you here? And it was especially difficult when Scotty turned 18 and the pediatrician came to us and said, we can't, we can't take care of him anymore. And we were really kind of like out there on our own for 6 years without a primary care doctor. And I went to Scott's neurologist, and I asked him, I said, so are you going to kick us out too? He goes, nah, you can just stay. And he's still seeing that doctor. He's awesome. And now he's, every time I go in, I'm like, you're not going to retire, are you? Because it's terrifying, because you develop a, a thing with the doctor, and the doctor knows your child, and it's really hard changing it, especially like for seizures and stuff, because the first thing the doctor wants to do, and we went through a number of them, is if they find out that Scotty still has seizures, they're like, oh, let's take him off of all of his medicine, start over from scratch, and then he goes into seizure status, and it's a mess. But anyway, so these are some of the ways we've accessed other supports, finding other doctors. And one of the other things that is really helpful is when you network with other parents of an individual with a disability. We just kind of have a little group networking going on, and that's been really helpful. Scheduling an appointment, if it's a new doctor before, I wouldn't tell them that Scotty had a disability, because I was afraid that they'd say no. But now I do. I tell them, and a lot of times scheduling an appointment is difficult for us in the morning because of all the morning care. It takes a lot of time and stuff. But the type of insurance, is, a lot of families, all they can access is Medicaid because of the child's disability. We've been really fortunate. My husband's company still has Scotty on their insurance, and then when he retires, then we'll go on Medicaid. But we request sometimes special I always do make sure that it's accessible for Scotty if there's no stairs, and most of the doctor's offices are these days. But if it's not, it's a really good idea, because you're not only going to use it for your disabled patients, but also for your typical patients, because at some time in our lives, I really and truly believe this, every single human being is going to be disabled at some point. So it's really nice to have the larger rooms, an exam table, and a lift system. And each person is unique. Each person is different. Take time to get to know your patients and ask questions. I mean, the reason why we're there in your office is because we're stuck, and we need somebody to help us problem solve. Get to know them. Health and safety, of course, is a priority, but ask them, who do you live with? Where do you live? Where do you work? How do you get around? What kind of supports are you accessing? And if you don't know, if you have another parent that is doing well with supports and stuff, connect them up. Start networking your families together, and we can help each other, because we're all in the same boat. How are they getting out of bed? How are they getting into bed? How are they getting a shower? That kind of stuff. All that, we as typical human beings, we do it ourselves, but you'll be amazed at how some of these individuals get around, and they a lot of the self-advocates that I speak to, I mean, their fear is going into a nursing home or into a facility. They love being out in the community, and we do have the supports out there that can support them so that they can realize their lives. You know, of course, all of the therapeutic supports, you know, the PT, OT, speech. Massage therapy is huge for Scott. It really keeps his muscles toned and you know, helps with his, oh, let's see, how do I, there it is, okay. Helps with his bowels and stuff, and but you know, ask the, you know, as far as respite goes, you know, if the main caregiver comes in with the individual, and especially if the individual is 24/7, you know, ask them, are they getting respite? You know, how are they getting a break? How are they getting around? You know, do they have bus passes? Do they have a car? You know, how are they getting to doctor's offices, to the grocery store to eat? That kind of stuff. And then all of the equipment and accessibility needs. I mean, we all need prescriptions for these for equipment and stuff, and that's where you guys come in. And Medicaid pretty much covers all of this. One of the resources that is out there, and every state has it in the U.S., is Developmental Disabilities Home and Community Based Services Waiver. And the purpose of this waiver is to provide services to individuals who qualify and to avoid the necessity of institutional placement. And what the individual does is they waive their right to institutional placement and choose to receive services in the community. Another resource, of course, is families, natural support, but then you really have to make sure that there's some respite in there and that they get a break. But how do you find that in your state? Just type into your search engine Developmental Disability Services in the name of your state, and it should come up. Every state is different. Probably, I don't know of a state that does not have a wait list yet, which is horrible, but you know, I would really love for this to be an entitlement, but we just have to advocate for that. But encourage your families and individuals who want to remain into the community to pursue these supports, because they are there. There's also the Developmental Disabilities Council in every state, and each state has one, and they have a lot of information about other state agencies and departments that can help individuals and families. They also have information about the Protection Advocacy Center. Oops, sorry. Let's see. ADA requirements. I'm sure you guys have all heard of the ADA, the Americans with Disabilities Act. It's a civil rights law that prohibits discrimination against individuals with disabilities in everyday activities, including medical services. The statute requires medical care providers to make their services available in an accessible manner. Public hospitals, clinics, medical offices, all of these that are run by state and local governments fall under Title II of the ADA, and private hospitals and medical offices fall under Title III. Both Title II and Title III require that providers provide individuals with disabilities full and equal access to services and reasonable modifications. I have to tell you, we have, our home has all, you know, because we've had Scotty for so long, our home is just totally accessible. And I call it like a universal design, and it has really, I can't imagine a house without ramps and wheel and showers, because we've all used it at some point. We've all used it. So if you can, because if you can get it done as soon as possible, then you don't have to do it again. Like I said, my neighbor next door who's elderly, I'm bringing her over here, giving her a shower in our shower because her bathrooms are not accessible. And So it's nice to have that. Accessible accommodations might include an access to your exam room, entry doors that are bigger and have accessible hardware, appropriately placed exam equipment, enough floor space. This is huge for individuals who are in wheelchairs, because we've got to maneuver around. Accessible exam tables. Some of these tables go all the way down, so an individual can just maneuver themselves over to the table. Patient lift, accessible bathrooms, scales, and staff training. This is really important to make sure your staff is trained in the operation of the equipment and how to properly assist with lifts and transfers. Another thing that patients might ask you to provide are interpreters for individuals, large print materials, and even allowing service animals to accompany them. But here's some additional resources and that you can access to learn more. So good luck, everybody. And now I'm going to turn this over to Carl.
All right, thank you. I'm going to turn the screen over to Carl now. And, well, if I can find him, here we go. Thanks, Charm. Sorry I had a little technical difficulty there. Carl, I'm turning over the presentation to you.
Okay. How's it looking?
Perfect. Thanks, Carl.
Okay. Well, welcome everyone, and Charm, I appreciate your presentation. A lot of good practical information. Under an Ohio Developmental Disabilities Council grant, our group developed a DVD that helps practices make many of the accommodations that Charm was talking about, and anyone who's interested in getting that DVD, you can email me at the email at the end of the presentation, and I'm happy to send you a copy. It's a set of 3 modules, one directed towards self-advocates, one directed towards families and direct support professionals, and one directed towards healthcare physicians and their office staff. So just to provide additional resources to tag on what Charm talked about. So today I'd like to talk about informational resources that clinicians might find helpful, and to talk about practice-based improvement using PDSA type of quality improvement cycles, particularly relating to improving the health and healthcare of persons with IDD. We need to look at how practice improvement is similar and is different when you're talking about improving the healthcare processes for people with IDD compared to the general population, or the population segments that are often the focus of practice improvement. And we'd like you to feel comfortable instituting a quality improvement process relating to persons with IDD in your practice. I'm going to use an example that we used in our own residency practice relating to cancer screening in this population to give you an example of how it's done and how it can be done. And then I'm going to present some electronic resources that'll be helpful for providing point-of-care information relating to clinical care of this population. So relating to quality improvement, why should we examine the healthcare of individuals with IDD? Well, first of all, there are some demographic imperatives, and Charm talked about the fact that the professionals at the time advised her to institutionalize her son, um, and fortunately for all, she and her husband elected not to. But now, how Charm did it is how most people are doing it, and most people with developmental disabilities are remaining throughout their lives in the community. Unfortunately, the community was ill prepared to provide and accept care of individuals with IDDD, and that care was often just provided without much advanced preparation, without much advanced organization or specialized funding. And what we're seeing, no surprise, is increasingly documented health disparities relating to mortality, morbidity, and quality of life in this population. What we're seeing is that acute and chronic medical conditions are not being diagnosed and treated optimally. We're seeing the same for mental health conditions. It's documented that there is suboptimal hearing and vision screening in this population, that there's health disparities in health promotion and disease prevention services such as breast and cervical cancer and colorectal cancer screening. And finally, there's documented disparities in palliative care received by persons with IDDD. So when we're looking at practice improvement, what do we need to consider? And how do people with IDDD differ from other typical target populations for QI practice improvement processes? Well, first of all, compared to other target populations for QI processes, people with IDD typically represent a small proportion of any primary care practice compared to often other groups that are targets for quality improvement are numerically much larger. So diabetics, for example, individuals with obesity, hypertension, hyperlipidemia are more commonly represented in primary care practices and often a more common focus for quality improvement projects. Clinicians are understandably less familiar with this population, hence the reason for webinars and opportunities for training such as this one. Often there is pressure to meet performance standards relating to chronic diseases like diabetes or hypertension, and so health insurance carriers are often not, to my knowledge, promoting quality improvements relating to this population as standards for practices, and they're not monitoring them. Clinicians are often unfamiliar with some of the service systems that Charm referred to for individuals with IDD compared to other target populations of QI, such as elders or people with more common chronic diseases. There are often very codified, standardized quality measures that are expected for the care of chronic diseases such as hypertension, diabetes, and hyperlipidemia, whereas among individuals with IDDD, quality standards are still in the process of development and are just emerging. And finally, there is a lot of published written experience about quality improvement in this population, in populations such as diabetics and individuals with hypertension or chronic obstructive pulmonary disease or chronic kidney disease versus there is very little written about quality improvement activities among and targeting individuals with IDD. So So that's some of the background that's relevant to talking about practice improvement and quality improvement targeting this population. One of the most important things when you're doing quality improvement relating to a numerically smaller part of a practice is developing a disease or condition or subpopulation registry. And if you don't do that, it's very hard to find these individuals. And you know, some individuals with IDD who have milder impairments are not always identified as such. So there's a whole issue of the unidentified individual with IDD um, at a state level, at a city level, or at a clinic level. There are different types of strategies you might use in developing your IDD registry. One is by using administrative data such as billing data, and so you can call your administrative billing data for certain diagnoses such as Down syndrome or cerebral palsy, intellectual disability. Of course, limitations of that strategy include the fact that clinicians often might provide care for a health condition such as hypertension, excuse me, in someone with IDD, and yet not include a diagnosis like cerebral palsy in the billing, and so therefore that individual might not appear in the administrative billing data set. A strategy that we used with developing our IDD registry was asking nurses, physicians to recall persons with a developmental disability whom they remember caring for and generating at least part of the list that way. Practices often have relationships with specific residential service providers. So, you know, in the residency practice I teach in Cleveland, you know, there are a number of agencies, nonprofits, an organization called L'Arche included, with whom we have a relationship, and we provide health care for many of the individuals serviced by these providers. And so, you know, the residential service providers can help a practice generate a registry list by just noting, you know, which recipients of their services are ones receiving care through that practice. And then, you know, using more sophisticated electronic health record strategies, you can define a list of ICD-9 codes that help identify persons with IDD and use your health system EHR networks and analysts to help you generate that list. And that's actually some of the research work I'm doing these days. Excuse me, I'm getting over a cold here. So many of you are familiar with QI processes. For those of you who are family physicians and have to do the maintenance of certification, of course there are modules, I think module 4 or stage 4 something modules that involve QI activities within your practice that are required, and probably all the primary care specialties are heading that direction of part of the maintenance of certification in the specialty relates to QI processes. The Plan, Do, Study, Act methodology is what's termed short cycle quality improvement methods, and it's a way to test a change that is implemented by going through the prescribed 4 steps of Plan, Do, Study, Act. It guides the thinking process into breaking down the task into steps, evaluating the outcome, improving on it, and testing again. And practices have been doing this kind of stuff for years, trying to improve care, often not officially using those terms or designations. But now it's more codified, and again, professional organizations such as the American Academy of Family Physicians is providing the template and the structure to do what people have been doing for a long time with off the cuff. For more information about this Plan, Do, Study, Act type of short cycle quality improvement, a good reference is the IHI Institute for Healthcare Improvement website. It's free, you can get a lot of materials, and it's good when you're introducing this concept to your practice. So again, Plan, Do, Study, Act involves generating a good idea, doing small tests of change, studying that change and analyzing what works, and then adjusting and doing it again. So this is referenced through the Royal Academy, Royal Australian College of General Practitioners, and again, it's very easy online. Just Google it to see how healthcare institutions apply the PDSA cycle to healthcare improvement. But step one is planning to test selected improvement or change. And you need to think about what would you expect to see as a result of this change, what data do you need to collect in order to determine outcome of the change, how will you know whether the change worked or not, and you have to decide you know, who's involved with doing the change, what are they going to do, where are they going to do it, and when, and how is the data going to be collected. Step two of the PDSA cycle is actually doing the test and collecting the data for analysis. The important thing when you're doing a short cycle PDSA improvement is not to get too complicated, not to get all-inclusive, not to make a perfect solution to a complex problem, but what you want to do are short incremental cycles repeatedly of change. And you'll see this in the example that we use regarding persons with IDD. Step three is studying the results. Has there been an improvement? Did it match what you expected to see? And what could have been done differently? And finally, step four of the PDSA is act on the result. Do an amended version of what you tried in the do cycle, and measure and study any differences in the results. An important part of any kind of quality improvement cycle is to make sure that what you've learned and what works in your practice through the PDSA cycle is then implemented and acculturated into your usual practice mechanisms in order to sustain that improvement that you demonstrated. And so what you might need to do in order to sustain that improvement is provide training and education of staff for short cycle QI projects. You may not include all the staff, all the physicians, all the nurses, and so when you're wanting to implement practice change learned from a smaller PDSA, then you need to train the entire staff, the entire group of physicians and nurses, for example, and you might need to make provision to retrain and update training and education over time. So that's something that particularly in practices where staff turnover is high, the issue of retraining and re-education is pivotal for sustaining improvement. That's clearly the case in a training environment like a residency program where I work. There needs to be standardizations systems and processes. So one of the things that can help practices provide patient-centered care is the ability to individualize care according to need. That has to be balanced with standardized systems and processes that help sustain improvement. Often that requires documentation of associated policies and guidelines, and then there needs to be ongoing measurement and review to ensure that the change is incorporated into routine practice. It becomes part of the practice way of doing things and part of the practice culture. So I'm going to then present an example short cycle QI project that we did here at our residency training program. This is a family medicine residency training program that's under the Cleveland Clinic, based at a community hospital where I teach geriatrics to family medicine residents, and where I also have a large subpopulation of adults with intellectual and developmental disabilities in my practice. And the intervention was a quality improvement project to enhance breast and colorectal cancer screening in adults with IDD. And it was part of a DD Council state-funded training project that wanted us to demonstrate healthcare outcome measures. And the intervention was a very simple electronic medical record delivered prompt to the primary care physician to order any deficient colorectal or breast cancer screening tests. The duration of that intervention was 3 months. So here's a graphic that kind of depicts the things you might think about when you're developing a quality improvement project relating to a screening. In this case, you can apply this readily to cancer screening, but it could be any kind of screening. It could be screening for visual or hearing impairment. For example, it could be screening for developmental disabilities in a primary care practice. This is just a screenshot of our chart audit instrument. So with having a registry, first of all, of people with IDD, and that was the pivotal first step, then excuse me, determining the focus for this project and the methodology, the intervention, then we had to develop a chart audit instrument, and this kind of tells you what we developed. Again, we looked at both breast cancer screening and colorectal cancer screening, and this is a screenshot of another part of the audit instrument that kind of depicts the things you need to think about when you're talking about, in this case, cancer screening, because not only it's a complex multi-step process, not only are you talking about identifying people who are eligible for it, identifying whether the physician has ordered the screening test, but then you know, was the screening test done in this population? Was the screening test attempted but not completed? So did the woman provided a requisition by the physician for mammography, attempt to undergo the mammogram, but experienced too much fear or discomfort from it and the test was abandoned? Did the individual male or female scheduled for colonoscopy begin to undergo the procedure, but the prep was inadequate? So those are some of the details that are relevant in terms of examining the whole phenomenon of cancer screening this population. And then this, again, is part of our data collection instrument that looked at what methods were used for cancer screening and what were some of the findings. What we found in our short cycle QI project was the following: that at baseline, 42% of individuals were women who were deficient in their breast cancer screening, and 32% of individuals were deficient in their colorectal cancer screening. What we found is that with a brief electronic medical record staff message delivered reminder to the primary care physician, 100% of deficient breast cancer screenings were ordered. 86% or 6 out of 7 of deficient colorectal cancer screening tests were ordered. Only 1 of 8 breast cancer screenings were actually conducted, and none of the colorectal cancer screenings were conducted within the 3-month time frame that we collected data. So our conclusions, and again, this is short cycle. This is looking at one piece of the puzzle, which is what you do with a short cycle project. We found that electronic medical record delivered staff messages were successful in prompting physicians to order deficient breast and colorectal cancer screening tests for individuals with IDD. However, uptake of cancer screening tests did not occur within the 3-month study period. So then again, what you do with a short cycle QI project is then take what you learned and consider what to do next. So for us, future QI projects will likely include the following. Number 1, a lengthening of the follow-up period. Since particularly for colorectal cancer, that's often a series of conversations to explain the test, the value of it, the risks, to allay fears, and to actually allow the multi-step process involving first seeing a gastroenterologist, then setting up a time for the actual colonoscopy. We need a better understanding of what are additional physician, caregiver, and patient factors that are affecting cancer screening uptake. Whether factors that are decreasing uptake or factors that are promoting uptake. And then we need to continue to implement small tests of change to increase the uptake. So we know with a pretty simple intervention, we can prompt physicians to actually order deficient screening tests. Now we need better understanding and interventions to improve the uptake of the ordered cancer screening. So that's the segment on short cycle QI projects within a primary care practice relating to this population. I'm going to shift then for the remainder to talk about electronic resources, information resources that clinicians can use, particularly point of care resources that'll be helpful in providing day-to-day primary care for this population. Here's an example from my practice, a woman I saw within the past couple months. Karen is a 24-year-old woman with a diagnosis of Williams syndrome, transferring care from her pediatrician to me. And the issue then is, where can a family physician, general internist, quickly find core information necessary to assume her care? So what are some syndrome-specific healthcare needs that Karen has, and what additional knowledge about Williams syndrome will assist the family physician in providing her health care? So if you learn nothing else from my part of the presentation, just learn that there is a wonderful information resource online that is free called Gene Tests, and you have the website there, and you can search either by disease, gene, or protein. And so here's a screenshot of the home page of Gene Tests. And then this is the search engine, and you see I typed in Williams syndrome, so by disease name. And then these were the hits, three hits that we identified, and clicked on the bottom one. and this describes Williams syndrome. And then this is the information that you need at point of care, is what are the syndrome-specific tests that the family physician needs to order. And so as you can see, it's a combination of screening for visual impairment, monitoring for hypertension, monitoring for disorders of calcium balance, monitoring by imaging of kidneys and bladder, monitoring for diabetes, cataracts, and valvular disorders. So again, this is pretty rapid point of care information. You can access quickly for free prior to seeing someone with a specific syndrome. This afternoon I saw in my clinic, I saw two persons with developmental disabilities. One was a gentleman with Down syndrome in his 30s, and you know, syndrome-specific issues there were he has cervical spinal stenosis with some degree of hyperreflexia, and MRI imaging of some compression, but not necessitating neurosurgery at this time. And that was documented, and that's syndrome-specific healthcare issue that relates to Down syndrome. And then the other thing that came up in the course of that consultation, again, was syndrome-specific, and that had to do with increased risk of gout in persons with Down syndrome. And he had been to the emergency room with sudden onset of wrist pain that was attributed to a sprain of unknown cause without known injury. I suspect in retrospect it was more likely possibly gout. Again, that's the kind of information you can quickly find through genetests.org. Another great resource is Exceptional Parent magazine, and those are very practical articles about resources and about conditions. Every year they provide a very extensive resource guide that's syndrome or condition specific, immensely useful. And this is targeting the entire disabilities community, including families, caregivers, physicians, allied healthcare professionals, teachers, and service providers. On the American Academy of Developmental Medicine and Dentistry, of course, is co-sponsor of this webinar series, and encourage you to go check out the AADMD website. There are PowerPoint presentations, and there's a lot of embedded information in that website, as well as a catalog of these webinars. This is the book it's a little pocket clinical manual. It's based on geriatrics at your fingertips kind of methodology. If any of you have ever referenced that pocket, clinical book, but it's a lot of bullet point type of quick rapid fire recommendations. What kind of things do you consider as a physician if you're evaluating someone with self-injurious behavior, for example? What are common neurobehavioral conditions such as stereotypies or movement disorders that is important for primary care physicians to know about and recognize? One thing that is emerging, that when I got involved in this area 20 years ago was not so prevalent, is finding information within general mainstream primary care medicine resources. And just looking up developmental disabilities in the AAFP website, you get a whole bunch of hits. There are articles. There's a slow small but steady stream of articles relating to developmental disabilities that do get published in American Academy of Family Physician publications, including the American Family Physician Journal. And this is worthwhile checking out because sometimes it does provide exactly information you want. I also encourage you to look at your usual electronic sources of information, and increasingly specific syndromes and specific developmental disabilities associated disorders are getting into electronic databases such as Dynamed or Essentials Evidence, and sometimes again you can find exactly the information you're looking for by just consulting a usual source of information that you use electronically on your iPhone, for example, Dynamed or Essentials Evidence Plus. So here are examples of the number of hits under developmental disabilities in Dynamed and Essentials Evidence. Again, if you're interested in the DVD modules about how to teach and train individuals with developmental disabilities to be more actively involved with seeking their health care, or modules relating to families and direct service professionals, and modules relating to improving the care provided by healthcare professionals and their staff and office teams, please email me and I'm happy to send you free of charge a DVD that we produced under this Ohio Developmental Disabilities Council grant. Feel free to contact me if you have any ideas about how your office is improving the healthcare of individuals with IDD. Thank you for your time.
All right. Thank you, Carl. For everybody watching, if you would like to get a certificate for attending tonight's webinar, just go to the web link shown. That's www.bitly.com/PEDD2012. From there, you just sign in or register. If you are registering for the first time, there will be an automatic email that will be generated and sent to you as a confirmation. If you don't receive it, just check your spam folder just to make sure it hasn't gotten lost there. If you have any issues signing on to the website there, you can go on to www.aadmd.org, hit the contact button, and you will send a message to one of us at the AADMD, and we'll be glad to help you. Once you're on the website, you can complete your CME survey about this particular presentation and also take the quiz. 7 out of 10 is considered a passing score, and then after you pass the quiz, then the certificate will be automatically displayed and also emailed to you. Okay, so Carl and Charm, I have a number of questions for you. And a number of positive comments from the audience. I wanted to read one, Charm, just off the bat here. I'm just going to read it verbatim because I thought it was great. It says, "Charm, you're a breath of fresh air. Thank you for your viewpoint from a parent. I am an administrator of the DD waivers in my state, and I'm happy to say there's no wait list here.
Wow.
More information on that later, because that is a very unique situation. Docs listening should know that parents need your help and scripts for prior authorizations in order to obtain some of those environmental modifications that Charm spoke of, which is why you need to ask those questions that she referred to. Waivers provide funding for staff, but can also pay for equipment and modifications for eligible individuals." But that comment actually came from the state of North Dakota. So for any of you DD directors out there, if you're wondering, how you can not have a wait list, you may want to look around North Dakota and see what they're doing, because it's apparently working up there.
I'll send families up there.
Yeah, exactly. So a couple questions. Let's see. I'll start with you, Charm. The one that we had was that you mentioned that you have some physicians in your family now, and we're wondering how that interaction with Scotty has affected them on a personal and a professional level. For example, is that why they decided to go into healthcare, or how has that affected them now that they are in the healthcare field?
Well, actually, it's my son, and he's an ER doc now. And when he decided to go into med school, I asked him. I was like, "Well, do you think, maybe it's because you grew up with Scotty that you want to become a doctor?" And he looked at me, and he had the funniest look on his face, and he looked at me and he goes, "Mom, I never thought of it that way before." So because Scotty was just his brother, he never thought of it. But when he was going through med school, when he was going through the part where they learn about seizures and stuff, he came home and he goes, "Mom, Scotty has them all." I'm like, "I know." And now, whenever, we have a challenge with Scotty, of course, he wants me to call him right away and tells me what to do. So he's really involved now. But it's really funny because the kids, as they were growing up, because, everybody was saying, that, keeping Scotty was going to ruin their lives, I made sure that I didn't use them as little slaves. And it wasn't until they went away to college that they came home and, then they started saying, you need to teach us how to take care of Scotty. So.
Oh, that's great. I'm going to give a little plug here to the AEDMB, and this might actually pertain to your son who's in emergency medicine, because we're going to be having a webinar series that's going to be coming up in the next couple of months about emergency care and hospital care for patients with IDD. So you might want to tell your son about that. We might have something to teach him if he's interested.
Yeah, well, actually, when he went through residency, one of the first things he told me, he says, "Mom," he says, when I see a kid like Scotty, I grab him because none of the other doctors know what to do with him." Yep. So, because he's been around Scotty, he's very comfortable with him, so he's teaching all of his peers. It's great.
That is great. Well, and another question about Scotty, as you mentioned, he's 38 years old. And so what are your concerns as he ages, and how does your family plan to address that?
Well, actually, we have a special needs trust set up for him. And, because he's on the waiver now, we didn't access the waiver actually until he was 25. So we've kind of like created a circle of supports for him, of extended supports. And like my husband and I, we're going up to a wedding tomorrow, and we're going to be gone for a week. So the caregivers are coming in, and then my daughter is going to be, she's working on her dissertation right now. So she's going to be coming home and doing my job, and kind of like, organizing, doing the nighttime care for Scotty. So, but both of the kids have said, they want to be involved, with Scotty. But, we'll just take it as it comes. But we really have it kind of figured out that he can just stay here in the home, and we'll just run circle of supports around him, the 24/7 supports.
That's great. And I think you've kind of alluded to this, but there was a question about respite care, and right. Really it was more directed to you personally. But the question really was, what do you do with that time once you mentioned that sometimes you need a break. What do you do with that time once you get it?
Oh, well, something as simple as going out to dinner and a movie with my husband.
Just to recharge the batteries, I guess. Charm, I had one other question for you, actually, and that was about ADA requirements, and that was if you've had any experiences with healthcare providers who weren't really observing the ADA requirements, or who were resistant to it, and if so, what did you do about that?
No, actually, I haven't had any problems with that. The like I said earlier, the only problems I had were doctors who weren't comfortable, um, with providing Scotty with services. But I mean, I've met 100 more doctors that were comfortable with Scotty and were really positive. I wanted to say that also. There's some really, if it wasn't for the great doctors out there, we wouldn't be where we are now, because really they were my lifeline, and they were the ones who said, well, just do this, and it was all kind of common sense stuff. So
Yes, well, actually, that's great that you haven't really had to, fight for wheelchair ramps, for example, outside of a practice office. I've certainly heard stories about that.
yeah.
But I think as the ADA's been around for a little while now, and everybody's at least starting to get the picture that it's not only the law, but it's the right thing to do, and I think people are starting to really follow those guidelines.
Yeah, well, the only place that we have that was a nightmare is when we took Scotty over to Europe. That was horrible. We kissed the ground when we came back to the United States.
So it wasn't quite as accessible there.
Oh, it was horrible. It was horrible. We'd have to take him in elevators and leave his chair down on the first floor.
Wow.
Yeah.
Well, we're doing a few things right here in the States then, anyway.
Oh, yeah.
Carl, I have a couple of questions that came across for you as well. So let me just ask a few. One was about the ICD-9 codes you mentioned, and somebody wanted to know if you knew specifically what kinds of ICD-9 codes we should be looking for in order to identify people with IDD.
Well, I have a short list and a long list. I mean, what we know epidemiologically about finding people with IDD in a population, the majority will be under the 319 codes that are related to intellectual disability, and so that's one major source of ICD-9 codes. The other is is the code associated with cerebral palsy. Another code would be chromosomal conditions. I mean, I have a list, and maybe we could post that. In some initial work I did on using the electronic health record to identify this population in the Cleveland Clinic system, I used about a half a dozen codes. I'm now working on a project, and I have about 20 codes, and added things like neural tube defects, for example. So I'm happy to share those codes, and maybe we could just post those to the AADMD website, and people can start to tap into those there.
Yeah, that would be great. Just after our presentation tonight, just email me those, and
Sure.
I'll work with John to get those put up on the site.
Great.
Another question was about doing the PDSA type QI project, and wondering what kind of man hours it takes, or person hours, I guess would be a better way of putting it, and how feasible it is for a small community-based practice to engage in that kind of project.
Well, I mean, I think again, I think that's part of the construction of any kind of QI project. Is it's got to be feasible, and it can't be excessively burdensome. And so you can ratchet your plan to how much staff time you have, and you can adjust your data collection method to what resources you have. A lot of practices can do things like just by filling out a little card. So excuse me, I think it is important to make any PDSA cycle not terribly burdensome. It's got to be the test of change, that small incremental change, has to be something that's worthwhile attempting or doing, but it can't tax the community practice excessively, or that'll be a huge disincentive.
Mm.
And so that's the balance. And I think every individual practice, kind of using their own kind of creativity, can decide how best to do it.
And this is the kind of activity that you can get CME credit for doing. Is that correct?
Absolutely, yeah, absolutely. And you can fill you can fill fulfill requirement for your maintenance of certification if you inform the AAFP, the American Board of Family Medicine, in advance. So you can't do this project and then later say, gee, can I get Module 4 credit out of it? You got to
Mm.
just inform them in advance and get pre-approval. So it
Well,
can, you know, meet multiple needs.
that's kind of nice because you're going to be spending that time anyway. So,
Correct. You have to, yeah.
and I guess a related question about this data collection is IRB approval needed for this type of data collection and analysis?
You know, if you're talking about quality improvement activities, that's considered part of standard practice, and you don't need IRB approval. You know, there is a gray zone between quality improvement and quality improvement research. And so if your intention, I mean, I think a good rule of thumb is, if your intention is, you know, I am going to present this for academic circles, as a poster presentation, or um, as a presentation in an academic meeting, or as a publication, then I think the safest thing to do is go through your IRB. And often, you know, projects like this will get what's called expedited approval without going through the whole process, because you're not subjecting people to anything unusual or harmful. You're just trying to improve quality of care versus giving a chemotherapy agent that's new, you know, for someone with cancer, that's untested, or, you know, phase 1, 2, or 3, or whatever. So I think often, you know, you can get expedited review if your intention is to, you know, publish this or present this in an academic meeting. Otherwise, you don't need IRB approval for it.
Okay, all right, that's helpful. I know that that question has come up several times in people that have been talking about this type of research. And then one other question was about the project that you did, and really it was more of asking you to speculate, I think, a little bit. But the question is, why do you think that those cancer screenings were not getting done, even though they were ordered?
Well, you know, I think there are a couple reasons. Number one is, I think there tends to be an underestimate of life expectancy of people with IDD by family members and support providers. And so uh, I think that's a huge factor. If you don't believe people are going to live long enough to get cancer, you're not going to go for a cancer screening test. I think another thing is an underestimate of people's tolerance for a test. So I think with adequate preparation, a lot of women with IDDD can undergo um, breast cancer screening, and surprise everybody. And in my experience, you know, what's worked are things like a mother going with her adult daughter with disability together, you know, for their annual mammogram. That demystifies it, that removes a lot of the fear, and I think adequate preparation. I had a woman with Cornelia de Lange syndrome, who, you know, started to undergo mammography, and what she and her family said was the key is the mammography technician taking the time to, you know, explain the procedure and allaying her fears. So I think that's another reason people don't even attempt the test. that's been ordered a cancer screening test is because, you know, they fear that the individual, you know, won't tolerate it. You know, cost and preparation complexity can be an issue. You know, mammography can be done on the spot, but, you know, colonoscopy is a big deal, getting the prep done. Um, and so I think the more steps in a cancer screening test, the more dropout there is. And um, I think also another thing is a kind of a bias that you know, the diagnostic overshadowing, where the focus is on the disability, not on the person as a whole, and there's a failure to incorporate family medical history of cancer into cancer risk assessment for the individual with developmental disabilities. And so you know, it's not even thought that, you know, boy, that person could die of cancer, not of anything related to their developmental disability. And indeed, the cancer is the third leading cause of death in adults with IDD, and but it's often not appreciated as such.
That's very well covers it, Carl. Thanks. Um, so thank you, Carl. Thank you, Charm, so much, and thanks for sticking with me, even though we had a little audio glitch there. I would like to thank all of you for attending tonight's installment of the PEDD webinar series, and especially like to thank our presenters. Please remember that in order to get your CME certificate, you must go to the website on your screen. If you have any questions or concerns, you can email me at mattholder@aadmd.org. And please join us next Tuesday at 6 p.m. Eastern for a presentation on behavior and medication management. And from all of us here at the AADMD, thank you and have a good night. Thanks, Carl. Thanks, John.
Thank
Thanks,
you.
Matt.
Our pleasure.